Hello everyone, and welcome to the Chronic Pain Self-Management Support with Pain Science Education and Exercise webinar. We're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as through donations and memberships to CIRPD. As I mentioned, my name is Tanya, and I'll be moderating the webinar and the Q&A session today. And our presenter today is Dr. Jordan Miller. Jordan is a physiotherapist and is currently a postdoctoral fellow at McGill University, supported by the Canadian Institutes of Health Research. He will soon be starting at Queen's University in Kingston, Ontario, as an assistant professor in the School of Rehabilitation Therapy. His research focuses on reducing pain-related disability through evaluating exercise and self-management strategies for people living with chronic pain and investigating new models of primary care for people with acute to chronic pain. Jordan also did a webinar with us, actually two, I think, way back in the early days of our webinar series, so we're very excited to have him back and to hear about what he is doing now. I will hand it over to you, Jordan.
Oh, thank you very much for that introduction. That was very nice, and also thank you to CIRPD and its supporters for supporting this webinar and for inviting me to come and speak again. I'm happy to be sharing the next hour or so with you. So as Tanya suggested, I talk over the next hour and also some chance for discussion, hopefully, is around self-management support, and in particular self-management support that incorporates pain science education and exercise. So my objectives over the course of the webinar are to provide a little bit of background, review the evidence on self-management, individualized exercise, pain science education, and what happens when we combine those approaches, so when we incorporate pain science education and exercise into a self-management framework. And I'll give an example of what that looks like when we integrate those different strategies, and then again I'll provide a little bit of time for some questions at the end. So the context is one that I think most people listening in will be familiar with, is that chronic pain is often associated with suffering and reduced abilities and difficulty participating in certain aspects of life that are important to people. The challenge is that we look at, and I put in quotes there, usual care, because I think that differs drastically depending on geographic location, but often care consists of medication prescriptions, but no exercise or physical activity recommendations. The challenge with that is most medications, including some of the effective pain medications that have a moderate impact on pain intensity, actually only provide a very small impact on function. And so exercise and self-management approaches may be a good strategy to help improve function, either alongside those medications or as standalone strategies. So that's kind of building the context for why self-management might be important. To be speaking about self-management, I think it's important that we define it, and I like to do so quite broadly in saying that self-management is the taking of responsibility for one's own behavior and well-being. And self-management support is the systematic provision of education and supportive interventions to increase people living with pain, their skills and confidence in managing their health care problems. And I think one common misconception about self-management is that self-management is at the exclusion of healthcare, and that one of the goals of self-management is to not need healthcare, and that's not entirely true. I think self-management usually has the goal of shifting day-to-day management decisions and helping people feel confident making those decisions, but it's not to shift away from use of people in the healthcare team. In fact, being able to navigate the healthcare system is an important self-management skill. So I think that's just an important thing to distinguish before setting out. And so why do we need self-management support? For people living with pain who are on the line, this is probably self-evident. People have to manage their conditions because they face self-management decisions every day. You know, how am I going to get through my housework this week? what should I eat today? Should I exercise? Should I go out for a walk? What do I do when I'm feeling stressed or angry or depressed? And when I have significant health concerns, who's the best healthcare provider to see? These are decisions that people living with pain are facing every day and making those decisions. And so the idea of self-management supports is to help prepare them to make informed decisions when they're making those decisions. The other reason why we need self-management support is from a healthcare system perspective. And in Canada, like in most parts of the world, we've got a healthcare system that's not prepared for the growing challenge of dealing with chronic pain. And so we need to provide supports for the daily management decisions of people living with pain so that healthcare providers are available when people need them for substantial healthcare concerns. And so before going into the example of how I approached self-management and the development of self-management program, I want to spend a little bit of time on the evidence. So self-management, a large portion of the literature is self-management for chronic diseases in a more general sense. So in these self-management programs, you'd have people with multiple chronic conditions. For example, you might have people with chronic pain, diabetes, heart disease, and osteoarthritis, all in the same group. And the evidence around these types of self-management programs, which are well established, is that there's moderate to large increases in knowledge throughout the program. There's small to moderate increases in self-efficacy. But when we look at some other outcomes like depression, where there's negligible to moderate effects, pain, where there's negligible to small effects, and function, where again there's negligible to moderate effects. Looking more specifically at pain-related conditions, so there have also been self-management supports for osteoarthritis that are developed. And that would include people in the group that would all share similarities in that they would all be experiencing influences of osteoarthritis on their lives. And in this particular population, a systematic review from a couple of years ago suggests low quality evidence that in comparison to attention control, the self-management supports resulted in no difference in self-efficacy, a significant but perhaps not clinically meaningful change in pain, and no difference in function. But I put a little asterisk there in that while this is a very high quality systematic review, there have been other systematic reviews in this area that do suggest some small changes in both self-efficacy and function. So the last piece of evidence that I wanted to go through was actually for chronic low back pain, where there's a systematic review came out earlier this year that suggested for this group that there were small reductions in pain and small reductions in disability for people with low back pain going through self-management programs. So to just summarize what a lot of volume of information in just a few slides there is that self-management interventions are quite diverse, and because of that and because of other reasons, the effect size estimates associated with those programs or how effective the programs are vary across studies, and when you group them together, you can notice that variance or that difference between programs. There does, however, seem to be some consistency in that people seem to increase knowledge and self-efficacy throughout self-management programs. But regardless of which condition, the results on function seem to be quite small. And so that's kind of setting the stage for why I thought I would investigate incorporating some other strategies in self-management, where I wanted to really see if we incorporate some different strategies, can we target function more effectively? But before going into that, I wanted to discuss what programs are already available there. So a group at Stanford, Kate Lorig, and other researchers have really done a wonderful job of developing self-management programs that started with a chronic disease self-management program, but also incorporates more condition-specific programming like the chronic pain self-management program, arthritis self-management program, and they're available across Canada, The challenge in providing Canadian-specific links is they tend to be quite different in their names even, but also in the contact information of how to get involved and how to get in touch with those groups. But what it would suggest is if as you're listening to this you think self-management programs is something that might be helpful for you, to really consider reaching out to that group and to even just doing a simple internet search on self-management, chronic pain self-management program and your geographical region will often pull up the information that you're looking for. So what most of the programs that have been well evaluated follow a similar format. And what that looks like is one session per week that's 2.5 hours long for 6 weeks. And in the Stanford Model Program in particular, it's facilitated by 2 trained leaders. At least one of those is a non-health professional that's living with the chronic condition. So for example, for the chronic pain self-management program, you'd have a peer leader that also has chronic pain that's been through the self-management program and has some ideas of how to incorporate that information and has had some success in doing so in their own lives. And the topics that are covered include dealing with frustration, fatigue, pain, and isolation. There's general exercise recommendations for strength, flexibility, and endurance exercises. There's a discussion of medication use, communicating effectively, nutrition recommendations, decision making, and how to evaluate new treatments. So a lot of good content built into those self-management programs. But as I mentioned, I want to describe how I went about developing a new self-management program that incorporates some different strategies. And the context for this is that Woodstock and Area Community Health Centre, it's a community health centre in rural southern Ontario, that's a multidisciplinary primary healthcare team. And like most community health centers, they have target priority populations of people that are underserviced or have barriers in accessing healthcare. So for this particular center, people with mental health concerns, addiction issues, poverty, isolated seniors, and people without health insurance would be some of the priorities for this community. And they identified a need for improved care for people living with persistent pain. For a while before I got involved in the community health center, actually the majority of visits to the primary healthcare team were related were by people living with chronic pain. And when the clients were asked by the healthcare providers, they felt like healthcare options such as physiotherapy or multidisciplinary pain programs were inaccessible to the population. And the healthcare team also felt that there was a need to offer services outside of medication and advice, which is where they felt a little bit stuck as a healthcare team in being able to provide services that really targeted function and help people participate and resume participation in aspects of their life that they'd have difficulty participating in. And so they reached out to us to look at developing and evaluating a new treatment option. And so as I alluded to earlier, the question that I was interested in from a research perspective, but also from a clinical perspective, is can we target function with a different self-management approach? So as we noticed, as we walked through the literature, that the effects of existing self-management programs on function in particular as an outcome were fairly small, and so I was quite interested in seeing what could we add or supplement alongside self-management to improve outcomes in what people were able to do and how they were able to participate in different aspects of their lives. And so a few differences from most existing programs that we were looking at is health professional-led versus peer-led program. And the main reason for that is to be able to incorporate things like individualized exercise and the behavioral strategies that would be difficult to include in a peer-led program. The individualized goal-oriented exercise, which have strong evidence pretty much across all pain conditions, where exercise seems to be more effective than comparison interventions or than most comparison interventions or control interventions for people living with chronic pain. Pain neurophysiology education, which is teaching people with pain about the science of pain, and as a strategy to target function, and then also some behavioral or cognitive behavioral strategies. Now, if people are ever searching this program afterwards, the title of this presentation was a mouthful, and so is the name of the program in the literature, which is Chronic Pain Self-Management Support with Pain Science Education and Exercise, with the acronym COMMENCE. And in the clinical community, though, some of the sites that are taking it up in Ontario currently are calling it the Living Better with Pain program, just in case you do see that available. And right now, I think it's being offered primarily at community health centers and family health teams in Ontario. But what the program looks like is twice-a-week visits over 6 weeks. One of those 2 visits is in a group setting, and one of those 2 visits is an individualized one-on-one appointment with a physiotherapist. And the emphasis of the program is on gradual increases in activities while controlling for symptoms. So it's really focused on that function and participation aspects. And what it does is it includes, as identified in the last slide, 3 components into the self-management support that haven't been included in great depth in existing programs, to my knowledge, which is the individualized one-on-one exercises that are based around the participants' goals, pain science education, and cognitive or behavioral principles. So I'm just going to outline a little bit of the evidence for why I thought it was important to include each of those strategies in a self-management program if we're wanting to target function. So pain education, pain science education that emphasizes cognitive, behavioral, and neurophysiological aspects of pain has been shown to improve pain, disability, self-efficacy, and negative cognitions associated with pain, such as pain-related fear or feeling overwhelmed by pain. It gets really exciting, I think, when we look at the evidence that pairs pain science education with activity or exercise approaches. Because the evidence, when those 2 are paired, pain science education and exercise paired together, the effect sizes become quite substantial, where there's moderate to large effects on function for people living with pain. And so I think there is the potential that pain science education may make the activity and exercise-based approaches more effective. And I've got some ideas of why that might be the case, although these are just my own thoughts and not based on solid evidence. But I think a better understanding of pain and why self-management strategies or exercise work may actually increase the conviction and confidence for change. So somebody that tells you to do an exercise, for example, that, I think if you do squats, you're going to get better. That probably, if you come into that not expecting that doing that exercise is part of your recovery or isn't going to make a difference in the things that are important to you, it's hard to want to do that exercise or to think that it's important to do that. But if I then gave an explanation for why that particular exercise is really important for you achieving your goals, and give a scientific explanation of how through doing that exercise we're going to impact pain or your abilities, I think that can be really helpful in increasing your conviction or your desire, your level of importance that you give it. I think it can also give confidence for change, understanding, for example, the plasticity or the ability of our bodies to change in response to a given input can give confidence that we can make changes through gradual changes in exercise and activity. And the other area where I think the pain science education, when pairing that with other treatments, can be quite helpful is that I think understanding the relationships between stress and thoughts and pain can be quite empowering and also lead to more effective engagement in other self-management opportunities. So there are a number of behavioral principles or behavioral strategies that have been incorporated through the program. I'm just going to walk through a few of those and then describe the example in more detail, an example of one. But the first is progressive goal setting. So it's an important way for participants and the provider to collaborate on a plan and to set out the future of what their relationship might look like. Having progressive goal setting, progressive meaning we're setting short-term goals, and once we're achieving those, we're setting an additional or subsequent goal. That may all be working towards a long-term goal that's set from the beginning. But having this progressive goal setting has been shown to increase motivation and adherence towards the treatments that might be involved in working towards that goal. And it's a really important component in both self-management programs and exercise interventions to involve progressive goal setting. Also, another behavioral strategy that's utilized in the program for those that it's appropriate is graded exposure. And so often certain movements or activities can become something that's feared by people when they've learned that they're associated with pain. So for those living with pain on the line, for example, if I asked you to think about an activity that before you even do it, you know it's going to hurt, and something that because you know that it's going to hurt when you do it, you've started to not engage in that activity as much as you would otherwise because it's hurt. And so that's an example of where there's could be potentially some fear of that activity or also just some avoidance of that activity as a learned activity. And a strategy for targeting that is slowly engaging in the activity in a gradual way over time, starting at a level and in a context which doesn't evoke a response, a painful response or a fearful response to that activity. And so for people who do avoid activities because they're worried that it's going to make their pain worse and that they may, it may affect the rest of their day because of having engaged in it, this can be a strategy that can help gradually work back towards those activities. Excuse me. Similar to graded exposure, but with a little different underlying principles, is graded activity, which I think can be really effective for anybody with a functional or participation goal. Somebody that wants to do more of an activity, graded activity can be a good strategy, and have been associated with improvements in pain and function. But essentially what that looks like is after having set a goal for an activity, laying out a graded activity plan would be, each week what are you going to accomplish that's a little bit more than what you did the previous week, so that you're starting at your current abilities and working with a graded plan to get to your longer term goals. Activity planning and activity scheduling is another component in the program. Most people with chronic pain, based on interviews, understand that exercise is beneficial, and many set goals of increasing participation in physical activity or exercise. But there's a gap between this motivation and understanding and those that actually achieve their goals of increasing activity. And activity planning is a strategy that can help actually increase the chances of achieving the goals that are set. So it forms a plan for how they're going to go about increasing the activity, a log to monitor progress towards that goal, and each of those things is an important factor at increasing activity. So that's a few examples of the behavioral strategies that are incorporated in the program. Next, I want to shift gears to exercise and why that's included in the program and why it's included in a specific way. So there's actually a lot of research, and this is one of my slides that I didn't include a lot of research or references at the bottom, because I think most people on the line are probably familiar with the understanding that exercise and engagement in physical activity has been shown to improve pain and improve function across multiple conditions: chronic back pain, chronic neck pain, fibromyalgia, osteoarthritis, just to name a few. And one of the theories behind the exercises in this program is that the exercises should be based on the participants' goals, and they should be individualized to the participants' goals and abilities. By focusing the exercises that are included on the participants' goals, I think that there is a stronger meaning to the exercises and a more likelihood that the person's able to stick with the exercises because of that meaning, because it's more likely to be working towards the goals that they have set. Interesting for low back pain, for example, well, there's lots of evidence to suggest exercise is effective for low back pain. Comparison between different types of exercise have shown similar results, suggesting there may not be one ideal type of exercise. And so one of the theories behind having it be very individualized and goal-oriented is that perhaps the best predictor of the success of an exercise intervention isn't the type of exercise, but whether or not the person's able to continue to engage in it over a long period of time. And so I think being goal-oriented and individualized is important to making the exercises meaningful and to making it possible for that person to continue to engage over an extended period of time, which will be needed to see long-term change. Also, there's an emphasis on aerobic exercise. So, interestingly, of the a couple hundred people that have been through the program, a very large percentage of them do set walking goals. And so even from the goal-oriented exercise, often aerobic exercise comes into the equation. But even for those that don't set aerobic exercise goals or walking goals or biking goals, we encourage in the program aerobic exercise. Because aerobic exercise can result in positive physiological changes to multiple systems that are involved in the pain experience, from the nervous system to the endocrine system to the immune system. There's evidence that regular aerobic exercise can improve function and improve mood, and may contribute to confidence in the ability to progress in other activities. So the aerobic exercise component is an important part of the program as well. Excuse me. So if we look at what actually happens when we combine these interventions, this slide shows the results of a randomized control trial that's under review currently that looks at the effect of this combined self-management program on function. I won't go through details of the measurement tool, but what is important to know is that lower is better on this scale, where lower means higher functioning or less disability. So the blue line is the people that were on a waitlist control. That waitlist was engaging in their usual care. So they were continuing to see their physician as they usually would, or other members of their healthcare team as they usually would. And the other group received the commence intervention, or the self-management support intervention. The program, if you remember, was 6 weeks long, so you can see during that 6-week period, that's when there's the slope in the line, where you can see that there's an improvement in function happening, and that over a 12-week follow-up period, after the end of the program, there's a maintenance of that effect. Perhaps a small trend, but we've actually followed people over a longer period of time that suggests that that effect is maintained. So even though it looks like it's sloping back upwards, people do seem to be able to maintain their function beyond the end of the program. So it does appear that combining a self-management support that incorporates pain science education, individualized exercise, and some behavioral approaches is effective at improving function. And the effect size was moderate here, so it is a larger effect than some of the other studies that have shown a small effect in function. So some future directions that I think are really important is as one might expect, the responses were quite variable, from people that had tremendous responses and huge gains and improvements in pain and function, down to people that were unable to see substantial changes. And one particular trend that was shown is that people with chronic pain and multimorbidity experience many barriers to attendance. Those barriers are quite diverse, but come with competing health concerns that they have to deal with, to inconsistent housing and having to find a new apartment to live in, to having caregiver responsibilities for their children or for disabled partners. There are many, many factors that that can pose barriers to attendance. And the research suggests that people that attend to a greater extent are able to participate fully in the program, experience much better outcomes. And so I think that we need an area of research is investigating barriers to attendance and participation and figuring out ways to help support people in ways that are in line with their other, other factors in their lives that might be affecting their participation. And that's really in line with other research in this area that suggests there are lots of potential barriers to participating, including personal factors like financial difficulties. It's difficult to afford bus fare or taxi fare to get to a program, for example. Depression and low motivation, the days where it's difficult to get out of the house and engage in the program. That can be a big barrier. People with mobility restrictions where they are unable to get into the location of the program. People with learning difficulties who may find it hard to engage in a group setting or in dialogue about pain science, for example. There are also system factors that can form potential barriers, like lack of self-management supports available in a geographical area, conflicting advice received from different healthcare providers, and access challenges. If the program's not offered at the right time of day, or if there's difficulty getting there by transportation, or if there's poor communication about the start of the program. These are all barriers that I've seen in the literature that I think we've seen at our sites as well. So now I want to go through what does this actually look like? How do we integrate a self-management program that includes pain education, cognitive behavioral principles, and exercise? I want to just give an example and use a case study to walk through that. Her name is June. And June has had low back pain and knee pain for 10 years, has difficulty going up and down stairs, and difficulty walking more than 10 minutes. And so the education that I might provide is around pain science. And so I might give an example of how there are receptors in your knee that are responsive to different inputs. And if those sensors get set off in a way that suggests to your nerves, something dangerous might be going on, like let's say there's a bit of inflammation there that isn't usually there, and your sensors get set off and they send a danger signal then up to your spinal cord. And at your spinal cord, that first nerve meets with a second nerve that sends a signal up the spinal cord to your brain. But at the spinal cord, it's not a simple relay station. We've also got input coming down from the brain and in from other tissues that can either make it more likely that the danger message gets sent to the brain, or it can make it less likely that the danger message gets sent to the brain. And so one example of this is if somebody rolls their ankle, or two people roll their ankle in the exact same way. One of them does it while walking out of their house to the car, and the other one does it while running away from a bear. Who is going to experience more pain when they roll their ankle? Hopefully with a bit of thought, you can arrive at the person that's walking out of their house to the car is likely to experience more pain because the person that's running away from the bear has bigger priorities. So this is an example of when the brain may say, I've got more important things to think about, and it may send a signal down to the spinal cord that actually blocks the signal. Or it might happen above the spinal cord at the brain, but it might block the signal to say, I don't need to think about that incoming danger signal right at this moment. On the opposite end of things, if you can also have input that makes things more sensitive. So you might have somebody that has persistent pain for a long period of time, and the nervous system has become very protective against their knee or their back in the case of June. And that could actually make it more likely that the danger signal coming in from the first nerve gets relayed up towards the brain. And an analogy that I like to use for that is that the spinal cord is like an amplifier on a stereo. And there are lots of things that can turn the volume knob up or turn the volume knob down. And often at this point in time, when going through the education with the person, we'll make a little list together. And so with June, for example, she wrote a number of things that turned the volume up, made her more sensitive or more painful, like stresses in her life, having done a big grocery shop, so physical things, having, again, caregiver responsibilities where she's caring for her husband at the time. Well, she identified a number of different factors that, that contributed to turning the volume up. But she also had some strategies to turn the volume down. Excuse me. She had examples of listening to music and relaxing. She enjoyed getting together with friends for card games, and that was a factor that she noticed less pain when she was doing those things. So there are different things that can turn the volume up and the volume down, and not all of these changes happen at the spinal cord, but it's one of the places where that incoming signal can be modified or changed based on what you're doing and the context around you. But for the purpose of the story, let's say the danger message gets sent up towards the brain. Once the signal reaches the brain, there isn't a pain area in the brain. There's a number of different areas in the brain that get the signal. As anybody that was listening to, I think Karen Davis did a webinar for CIRPD not too long ago, who is an expert in the brain imaging areas, areas of the brain involved in the pain experience, and so anybody that saw some of her images would have noticed that that there are lots of different areas in the brain that get the danger signal or nociceptive signal. And because of this, pain can influence our thoughts, pain can influence our emotions, pain can influence our stress response systems, and vice versa. Our thoughts can influence pain, our emotions can influence pain, and our stress response systems can influence pain. And so pain becomes very complex because of all the different areas that are involved. And your brain's left to conclude, given all of this information, what is my best response? And if it decides it needs to protect you, then it might output pain to that area of the body. It might turn on some muscles to stop you from moving as well. Or it might cause some weakness. It might release some chemicals to help respond. The result of some of these changes that take place over time is a change in our alarm systems or our thresholds. So on the left, if I'm climbing up this dial, I get to a certain point that's my tissue tolerance. That's the point at which I cross, and I might actually injure something. So I might sprain a ligament or strain a muscle. Just before I get to that line, I have the onset of pain or an alarm system. And when that alarm goes off, that's our body's way of protecting us before we get to the point that we do any further damage. Now, after you've had an injury, or especially after you've had pain for a long period of time, the lines change. So the tissue tolerance comes down a bit because you might not, for June, she wasn't using her knee the same way she was before. She wasn't moving her back the same way she usually did. So her strength in that area, or tolerance of her tissues in that area, might be a little bit weaker. But in most cases, or all cases perhaps, the onset of pain comes down quite a bit further. So we're going to get an alarm long before we get to the point where we do further damage. That can be really helpful for short-term injuries because for the person that rolled their ankle while walking to the car, for example, that person is going to get messages to help them stay off their ankle while it recovers, and by staying off their ankle, they're going to have the chance, a little bit better chance of their tissues healing. And what often happens is as that ligament on the outside of the ankle heals, the onset of pain line comes up along with it, and so it's a protective mechanism that's shorter lived. But in 1 in 5 people, even after an ankle, rolling your ankle, 1 in 5 people go on to experience chronic lateral ankle pain. So in certain circumstances, that for some reason that alarm system stays sensitive for a period of time beyond the injury. And it doesn't even have to start with an injury. It can start with a gradual onset of pain, like in a condition like arthritis. Or conditions that are harder to explain the onset at all. But what the positive is that we can use this information. we know that we can work to the point where we feel pain without being worried that we're doing any further damage, as long as we don't blow through that line really quickly. But there's another line that I'll call the flare-up line. And if we call that more pain an hour or two after an activity than you had before, then we may want to think hard about whether or not we want to push beyond that. So the way I posed it to June is I gave her 3 options. I asked her, what happens if we aim up here? What happens if we say, doesn't matter what my body's telling me, I'm going to push through, I'm going to do the activity, I want to walk more, I'm going to do it anyway, I'm just going to push, push, push. And I think she responded the way many of you would respond and said, well, if I do that, it's going to get worse. I'm going to flare up, I'm not going to be able to do as much of it tomorrow, and over time it'll get more difficult, which is often the trend we see. If we continue to flare up every time we do activity, the activity often doesn't get easier over time. So the second option I said is, what happens if we aim down here? What happens if we aim prior to the onset of pain? So she mentioned her ability was walking 10 minutes. I asked her, what happens if we never walk more than 8? Does walking 11 minutes get harder or does it get easier? And she accurately identified that probably it's actually going to get harder or stay the same. It's not going to get easier if I never challenge it close to my limit. And so that left the third option, which is, what if we aim in the middle? What if we aim at the point where we say pain at the time of doing the exercise, that's going to be okay. While we're walking, it's okay if I experience a little bit of increase in my knee pain or my back pain, but I don't want to go to the point where it lasts afterwards. An hour after doing my walk, it shouldn't be any worse than it was before I started. And if we do that for an extended period of time, so we always aim just above that that onset of pain line, where we say pain at the time is okay, but not to the point that I'm paying the price for a long time afterwards. And what we often see, if we stick with that for a long period of time, is that you're able to do a little bit more before experiencing an increase in pain, and you're able to do a little bit more before experiencing a flare-up or pain that lasts. And so 6 weeks later, maybe she's able to walk 15 minutes instead of 10. And if before she was flaring up at 15 minutes, now maybe she was able to go 20 minutes before the pain lasts after the end of a walk. And eventually you can even see changes in the tissue tolerance or the ability or the strength of the tissues in that area. But often that doesn't change until the alarm system becomes a little less sensitive first. So that's a little bit an example of some of the education that we might provide. And I hope to link that now with what we did as far as exercises and hopefully you'll be able to see from that how pairing some of the pain science education with the exercise can be an effective combination. So we did 2 types of exercise with June. The first type of exercise was frequent movement that doesn't make your pain worse. So I asked June, if we're focusing, I'm just going to speak to the knee, even though she had knee and back pain, we were actually going through 2 sets of exercises at the same time. But just for ease of communicating, I'll just focus on the knee exercise. And so the frequent movement that doesn't make your pain worse, she said bending and straightening her knee. And I said, okay, great. How many could you do without feeling an increase in pain? And she said, I could do 8 to 10 probably. And so she worked away at 8 to 10. And along the way, I reminded her that for this exercise, the key was frequency. I wanted her to do it regularly through the day. So every couple of hours, she's bending and straightening her knee 8 to 10 times, and she's doing it at the level that doesn't increase her pain, even at the time, because of the frequency with which she was doing it. The second type of exercise was a little bit more challenging. It was working to the alarm without flaring up. And so you remembered she mentioned difficulty with doing stairs, and so we tackled stairs, where first she started by stepping on top of a book, and then gradually we increased the height of the step to a full stair. These aren't actually her legs or feet, but they're gradual increases in the height. And I asked a similar question to her at the beginning, is we want to aim here. We want to aim to the point where pain at the time of doing the exercise is okay, but we don't want to flare up afterwards. How many steps do you think you can do to start on the book? and she started with 6 steps on the book. And within 6 weeks, she was doing 12 steps on a full height stair. So gradually, those onset of pain lines and the flare-up lines increased, and she was able to increase how much of the exercise she was doing along with it. But the main difference between this and a lot of exercise programs is, I think, really framing it using the pain science as a basis for how much of the exercise we're going to do and how we're going to progress it over time. The example I want to show for the behavioral approaches is a goal setting and graded activity. And so I asked her an activity that she'd like to do more of, and the first thing she identified was walking. So then we worked together to set a short and long-term goal. I'm not going to go through the details of a SMART goal today, but it was important that it is specific, measurable, action-oriented, realistic, and time-bound. And so her short-term goal was to walk 15 minutes daily within 6 weeks, and her long-term goal was to walk 30 minutes daily within 4 months. And so we wanted to go about a strategy of how does she get from where she is today, which is walking 10 minutes, as much as she could walk without feeling like she's going to pay the price later, up to where she wants to be, which is 30 minutes. And to do that, we set out a graded activity plan. So we laid out a number of weeks, and a general rule of thumb that I think I shared in my last webinar with CIRPD actually, is the idea of a 10% increase per week being a good level to start with as far as a change from 1 week to the next. And so she started with where she was confident with 10 minutes per week, or 10 minutes per day throughout the week. And we increased by 1 minute, which meant she went up by 1 minute until she got to 15 minutes. And then her 10% of 15 becomes a little bit greater, so she went up by 1.5 minutes, and then eventually started going up by 2 minutes. And so our plan was laid out over a 14-week period. Now she did achieve this plan. She needed 2 extra weeks to accomplish it because she had a little setback along the way, which is not uncommon. So she had a plan, but she was ready to modify it in response. So she did reach her goal of walking 30 minutes within the 4-month period. She's not having difficulty going upstairs, but still has to place 2 feet on each step on the way down. So I hope that using June as an example, it helps to show how we can integrate the 3 different concepts within a self-management program. The pain science education, understanding how the sensitivity of the nervous system can be modified through different activities, including exercise and graded activity. How exercise can be incorporated alongside that, and how this can be done alongside a planning or behavioral approach like goal setting and graded activity planning. So I want to make sure that I do leave time. I see it's getting to 10:02, and I do want to make sure I leave time for some questions. But I wanted to finish before that with just how do I use this information? And so at the heading of that slide, I said, I'm living with pain, how do I use this information? The first thing is consider a self-management program. If what I described today sounds like something that would be helpful for you, consider looking at the resources in your area for self-management programming. Alongside that, if you feel like you need extra support for changes in physical activity or exercise, consider seeing a physiotherapist to support these changes. Some of the examples I gave about individualizing exercises and how much should I do to start, and how do I progress over time, and what's the best exercise I can do for my particular, here's my goal, what's the best exercise I can do to achieve that goal. Those are some of the things that I think a physiotherapist can really help support. And at least the early evidence, and I don't want to overstate the research that we've done so far, but some of the early evidence at least suggests that that maybe pairing exercise, behavioral approaches, and pain science education may, alongside a self-management framework, may help to improve those functional or participation outcomes. So if those are the goals that you have, is what you're able to do, and getting back to participating in those things, then you may want to consider some of those supports. And similar, I left this blank. There's supposed to be a dot, dot, dot. If you feel like you need extra pain science education, I think that there are multiple people that you can reach out to. Physiotherapists might be one of them if you're already seeing them for support with physical activity and exercise changes. But there's other healthcare providers that could also fill that role potentially. So the second take-home point is I'm a healthcare provider working with people with pain. How do I use this information? The first is I would be aware of self-management programs in your area. Be aware of the resources that are available so that you can direct people to those supports when they're of interest and in line with the person's goals. And if your client or patient has a function or participation goal, consider the importance of individualized goal-oriented exercise, pain science education, and strategies to support behavior change. Those may be important factors for reaching function and participation goals. So at that, I'd like to say thank you to everybody for your attention. I hope you're able to take some helpful information away from this presentation. You're welcome to contact me by email, and I look forward to answering some questions.
Great. Thank you very much, Jordan. That was a really good presentation. I had a question. We haven't had any questions submitted just yet, so please, everybody, type in any questions you might have related to the presentation. And while we're waiting for that, I had a question. One of the barriers I know in my work as I'm finding resources for people with chronic pain is a financial barrier in accessing particularly physiotherapy as an option, like a treatment option. What would you say around that, and as well as how does that apply your new self-management program? Is that covered by broader healthcare coverage, or is that something that is more of an extended benefits, like kind of that monetary piece to it?
Yeah, I think that's so important, Tanya, and thank you for bringing it up because I should have tackled it head on. So in Ontario, where this is being offered is at community health centers or family health teams where the physiotherapist is in a salaried role, and sometimes the program's actually being carried out by multiple disciplines as part of that primary healthcare team. And so where it is available free as a free resource to members of those or people registered with those healthcare teams. But that's pretty location specific. It's all in Ontario, and it's actually only at, I think, 9 sites now. And so to have that in your area is challenging. To answer the question about accessing physiotherapy services I think that's a tough question to answer in a national webinar, because so many healthcare system factors are at the provincial level. And so in Ontario, for example, we have differing systems. So we have a private physiotherapist coverage, which for people with private insurance or ability to pay out of pocket, that can be a good option. We've got an Ontario health plan covered physiotherapy, which is available to people over 65, under 19, on disability insurance or had a hospital stay, such as a surgery. And then there's community health centers with physiotherapists who try to meet the unmet need of people in their communities or geographical areas. Now, I know there are some provinces that are similar to Ontario, but there are others that are not, and that in particular, the last 2 options that are covered by the Ontario Health Insurance Plan and at community health centers and family health teams are inconsistent as to whether they're options depending on the province that you're in. But what I would say is that I hope that reaching out to your primary healthcare team or your primary care provider would be a good option in getting some information about that. And the last point on my long-winded answer to a really good question is around the self-management supports, which are available fairly consistently across Canada. And so even it won't be necessarily physiotherapist-led, but you might have access to some self-management supports that are available, and in a lot of areas underutilized. So again, I didn't want to put a long list of, because I'd have to put a website up for every province and even regions within provinces, so it became an overwhelming list even when I started to compile it. But if you have trouble tracking it down with a simple search, by all means reach out and we can try to direct you to the right contact.
Wonderful. I was going to say, I was going to post for sure some links to some of the ones that I know for sure. And then I'll also, I think the Canadian Pain Coalition has a pretty good list on their website. So I'll double check that, and I was thinking I'll try and post some of those types of resources for people after the webinar, just so people have a place they can go and look.
I think that sounds like a great plan.
Wonderful. Let's see. So we have gotten a few questions here. Let's see. So someone who's been diagnosed with Ehlers-Danlos syndrome, and just saying that they have had trouble finding self-management guidance because most people are affected differently, and wondering if you have tips on where to look, who to ask, because doctors have tended to just say, like, just avoid doing what hurts, versus actually tackling the idea of, you know, pain thresholds and all of that sort of stuff that you mentioned in your presentation.
Yeah, I think that's an interesting question. My experiences are that when I'm engaging with people with conditions that and perhaps unique presentations and experiences, that can actually you know, it sets up a really good partnership where, you know, I can't know that information as a healthcare provider, and the rest of the group members can't know the answers necessarily because everybody is different. But it doesn't mean that sharing the experiences of what have worked for other conditions can be helpful. So I think looking for a more general chronic pain self-management program is probably a really good option, but then just making an extra concerted effort to open those lines of communication, recognizing, as everybody should, that pain's a very individual experiences, and the sequelae or the impact that it has on each person's life is quite different. So I don't know that it has to be a unique challenge in finding a program. It just might be extra support in the communication, in thinking about, you know, how do I apply this myself? How do I take that information and apply it in my own day-to-day?
Very good. The next question's from a healthcare provider asking, how can we educate clients with chronic pain that feel that passive therapy is the only thing that works for them to adapt to more of a self-management program?
That's a good question too, and I must say I have experienced very little resistance in this way in the settings that I practice in, and part of that is the last few years of practice. I practice in primary healthcare settings, and I think there's perhaps a little difference in expectation versus a private clinic where people have heard from their friends that you go in and you get some manual therapy, for example, and that's how they go in with the expectation that there's going to be that passive treatment. I often bring in the evidence to the conversation and saying that you know, most people identify the reason that they'd like to come for therapy is to make long-term changes in what they're able to do and how they're feeling. And passive approaches like modalities, like use TENS as an example, which a lot of people will be familiar with, like the tingling across your skin, the electrical current that's sent across your skin, or manual therapy, often are associated with short-term benefits but not long-term change. And so I match it up between, I often have a conversation that's matching up between what the person identifies as a goal and what that particular treatment option can offer. And often that leads to a really valuable discussion around, you know, maybe they are looking for temporary relief and a hands-on approach could be helpful if they're in the middle of a flare-up, for example. But if they're looking for long-term change, to help them understand that, you know, an activity or exercise-based approach or self-management approach is much more likely to have long-term changes, might be a way to engage in that conversation. But that's a difficult, my asterisk at the bottom is that's a difficult conversation to have, not knowing the person that's there in front of you, and they have to be open and consenting to the approach that you're taking. It needs to be a mutual decision together that you work on.
Great. Someone asking, as somebody who's in rural areas that may not have resources you've outlined, they in particular live in rural BC, wondering what options there might be.
So one particular option is, I hesitate to promote a particular program, but is online self-management programs, for example. And BC cued me to that is that Neil Pearson has developed a program, I believe it's an online pain care program that might provide access to resources online. The other option, I think, is connecting through your primary healthcare team, who sometimes have resources available via telephone or video conference or that kind of thing. So those are the two options that come to mind as immediate solutions. I mean, I'm involved in some advocacy work, and hopefully there'll be a little more consistent access to programming over time, but for now I think looking at online self-management programs and connecting to resources that might be available through your primary healthcare team are the two options that come to mind for me.
Great. Yeah, Neil Pearson, he does have a good program. It is, you have to purchase it. I'm not exactly sure what his schedule is, like what the payment is. But the other option in BC for this woman in particular is the University of Victoria does the self-management program, and I believe they have an online option as well. And it is free.
I wasn't aware of the Victoria one. Yeah, that sounds like a good option.